Hello, this is Tim Mullett. I'm the current chair of the Commission on Cancer, and it is my distinct pleasure to be able to meet back with a friend and to have a chance to have a conversation with Dr. Alfred Cohen. Dr. Cohen served as the director of our cancer center, Markey Cancer Center, several years ago, and during that time was uh, I was fortunate enough that he asked me to serve as the chair of our cancer committee. And from there, Dr. Cohen has gone on to a distinguished career and has continued with his impact in the cancer space. But uh, along the way, he had the opportunity to serve as the chair of the Commission on Cancer. And that was certainly a great opportunity for me to be able to have the chance to come back and have this conversation with Dr. Cohen and learn more about how that role as the chair influenced him and how he was able to uh, make a positive impact on the commission and cancer in general. Dr. Cohen, welcome.
Thanks, Tim. I might start out by saying, as a academic at major medical centers and dealing with people who spent their lives treating cancer patients, it became of great interest to me in the late 90s to realize that something I think everybody's now familiar with, 80% of all cancer care happens at the community level. And the cancer centers, the NCI designated centers, really play, although they may play a leadership role in much of research, but the reality is quality cancer care happens primarily in the community. And the commission, as you've pointed out, is now 100 years old, has made to me, the biggest impact is the added value was to recognize the need for tumor boards, multidisciplinary care, registries, cancer registries, annual reports on new cases, the quality of cancer care. It's made a huge difference countrywide. And the Commission on Cancer, which is focused on the whole quality from my perspective, really was has taken the lead. And the fact that it's in the surgical world is important. One of the things that I noticed early on is establishing multidisciplinary care at community hospital involves tumor boards. And when I started in my 4 years of leadership in 2000, the real challenge was how to get surgeons involved, because these tumor boards frequently were lunch meetings. And if you have a meeting at 12 o'clock, the reality is you're not going to get many surgeons to attend. Very hard to get surgeons not only to attend, but to take a leadership role in these tumor boards. So that's where I spent most of my 4 years trying to break through the problematic aspect of getting functional tumor boards in the community hospital, getting them approved and really impacting just the nuts and bolts multidisciplinary care that was taken for granted in the 80s and 90s at major medical centers, but less so in the community hospitals.
I think that's a huge shift in that era when we began to recognize the value of bringing tumor boards directly into the community, and your focus on that was seminal, because that became, in my language now, that's really the heart of a quality cancer program, is what happens in the tumor board. because that's where you really discuss the true multidisciplinary management, the communication, the coordination of care. And as we've gone further, now we've got not just the providers that are in terms of therapy, but we've got all the other elements, whether it's the clinical research associates or whether it's pharmacy or nutrition, nursing care, all of them are now present at the tumor board. And that's been an interesting shift in this era now with one of the bright spots perhaps of COVID is the fact that we've all transitioned to this virtual world. And so that's actually allowing more and more participation and really facilitated that. But I think you're right. When we really focus on getting the surgeons into the tumor boards and engaged, then those tumor boards really do shine.
I think you articulated some of the really important things that have gone on really over the past decade, actually. And it's happened at medical meetings. They're no longer just surgical meetings. They're medical oncology meetings or radiation therapy meetings. So even from the professional society point of view, they recognize the importance of education and interaction in terms of multidisciplinary care. And it's now, over the last decade, expanded further. So we have genetics counselors attending meetings, as nutrition people have attended. One of the really great things, even making rounds in inpatients, we have pharmacists now making inpatients. That was not heard of 20 years ago.
But it's a key feature now.
It's now, how could you possibly go back? And if patients or nurses think doctors know all there is to know about drug interactions or what drugs are best for certain things, particularly if it's out of your own area. I mean, we have so many patients on anticoagulants. So when should that be stopped before elective surgery? What are the drugs that interact with radiation therapy or chemotherapy? So I think there, over the last 20 years, it's just been a dramatic change in all of medical care, but particularly the broad impact. And we might mention one other thing, the impact of patient advocacy. Has also made a huge difference. In my own area of colorectal cancer, focusing in on the quality of life issues in terms of what patients will put up with to avoid a colostomy bag. And these are sort of important things that have helped us bring multidisciplinary care to treatment of rectal cancer. It has had a huge impact on the number of colostomies every year. And even in patients with colostomies, now following up on the issue of multidisciplinary aspects, we now have and expect to have enterostomal therapists in medical centers.
Absolutely.
And even independent outpatient enterostomal therapists to help patients in that regard.
Well, huge changes, no question. And again, I think your leadership with the tumor boards was critical. Now, but you mentioned how important you felt the CoC was in that regard. What brought you? How did you get engaged with the CoC in the very beginning?
Well, I was in an institution that had a number of other leadership people that were involved, and I got increasingly interested in the implications of cancer care in the community. And so I got involved with cancer registries. And if you're interested in cancer registries, both at the hospital, the community, the neighborhood level, or your state level, you naturally turn to the Commission on Cancer, which is a home for much of this activity. So
Well, the CTRs are critical to our existence, and so when you're talking to the registry, you're definitely working hand in hand with those registrars, and they definitely value what happens with the CoC.
the registry, this is how it all started 100 years ago, with trying to keep
Ah,
track of what were the cases and the end results, et cetera. It seemed like a sort of an obvious thing to do, but it's made a huge difference. And as you said, there is nobody more committed than cancer registrars. Wow,
amen.
they are
So,
something.
you've had the chance to see the commission from all perspectives, really, and you've worked with community programs when you were in Arizona, and you've worked in South Carolina now, and you've continued with your work in industry, and yet the commission seems to show up in a lot of these different areas as we look at whether it's tracking cancers or measuring quality or trying to collect some data for studies. Where do you see the value that the CoC brings to improve quality for all of our cancer patients?
I think the operative word is quality, is that the level of your cancer care shouldn't be determined by your zip code or what state you live in. And the reality is most patients can't travel long distances for care. And so we need to push ahead to make patients feel comfortable that they can get quality care. That doesn't mean that there is not still, of course, there'll always be a major role for centers of excellence. But for most patients who have colon cancer or lung cancer, breast cancer, there's no reason they shouldn't have state-of-the-art care in their community.
Excellent. Well, we're certainly trying to carry on your tradition, and we've been able to do that with the development of a network here in Kentucky that's connected to Markey Cancer Center, and I think that's been a model that we're interested in. To your point, trying to find ways where we can increase the quality of cancer care in the community programs, but maintain a connection to the medical centers from the NCI or from the larger programs that are in the region of all of these communities, so that there's a more of a collaborative feel for these, and I think that makes everybody better.
I think that the physician and the support staff community plays a key role in the prevention field, something I'm now devoted my last decade involved with. And even when I was at Sloan Kettering, I used to drive my fellows and residents crazy, because after I see a patient and scheduled surgery, before I said goodbye to them, I asked them whether they wore seatbelts or not. And people would shake their head. But all of us need to focus in on dietary issues, on practical things, on when you see children, when you see young adults of your patients with cigarettes sticking out of their pockets. So we have to always sort of think about, particularly now, even in the genetics world, and so many inherited cancers. So we have to be aware of it, spend more time. We're all somewhat busy, but we need to keep the bigger picture. So don't smoke, wear your seatbelt, eat a reasonable diet, and exercise can make a big difference. Just focusing in on curing the cancer is just the beginning.
Exactly right, and this is I'm seeing this more as an opportunity to be able to meet with patients, and not just my patients, but now with patients from all of our programs, and to find areas that we can connect with, such as tobacco treatment when we're talking to patients about lung cancer screening, such as being able to talk about nutritional issues or dietary control. And so these are because they do have such an influence on other risk factors. And as you mentioned, I think that the patient in the room may not just be the one that has cancer that we're talking to right there, but it's actually the family members and the other folks that might be influenced by secondhand smoke or might be influenced by other areas.
Absolutely. To me, the huge opportunities dealing with the reality of family members, friends, they all are impacted in that regard. And so one thing, Tim, that I did not succeed, but I thought I was such a great idea in terms of cigarette smoking cessation was a deal with the OB community in Kentucky. I had set up a number of meetings to try to, I couldn't really get their interest. When somebody comes in who's pregnant, most of them will stop smoking during their pregnancy, and most of them have husbands who smoke. And it's a huge opportunity to make a difference in terms of smoking, because if these people are 25 to 30 years of age, they stop smoking their risk for lung cancer is reduced by 90% if they stop at that age, and
vanishes,
and their cardiovascular risk tends to disappear. So it's to me a huge opportunity. I could never really get the OB community to want to devote time to that, but
well, I think
I gave it a go.
That's important, though. I think that's a great connection, and I think that as we look at the role of the CoC now, and really understanding the continuum of a cancer patient begins with prevention and goes into early detection, not just in the treatment phase and what we do in the operating room or how we handle patients with other treatments, but it also goes all the way through survivorship now and monitoring patients for their next cancer and surveillance. And so I think that it's important for us as cancer leaders to be able to make sure that we're reaching out to impact the entirety of the spectrum of patients at risk for cancer as well.
Well, Tim, congratulations on your involvement. They're lucky to have you, and you're obviously committed.
Well, thank you. It's an honor and a privilege, and it is. And you're right when you talk about other people, because it is an incredible team that we are working with. The other leaders that I work with, the staff that are present, as you recall, are dedicated, like the CTRs and like the program members that we deal with. And so it is that's what makes this so much fun, is the opportunity to really get to know these committed professionals. But thank you for your leadership and bringing us forward, and frankly for bringing me forward into this element. And I appreciate that so much. It's great to see you.